tries, if the baby doesn't get milk, he tries to adjust his mouth or head position, and he tries to locate or take the mouthful of the breast. So baby will not become comfortable. So baby feeding comfortably. Second, there will be deep jaw excursions with a pause preceding each follow. So when baby breastfeeds, baby suck, swallow and breathe. So 2, 3, 4 sucks, then baby swallows, then breathes. So baby takes a pause for breathing. So that is another good indication. Then audible swallowing with the sound from this throat. This gulping sound of milk will come. So we ask mother to hear that gulping sound. It is if the baby does only while feeding, if the baby makes sound like this, that means baby is not getting milk. The chuk sound is the baby is saying it is chuk or it is wrong. So we need to adjust the positions. Even this sounds helps in identifying the correct latch. I again want to highlight one more incident with our IBCLC Dipti Shah, when she was visiting during this COVID pandemic. Nowadays it is a virtual consulting even with the breastfeeding mothers. So when she was consulting, she heard that different sound of sucking while the baby was feeding. Therefore, she asked the attending pediatrician to just check the baby's mouth. And when the pediatrician checked the baby's mouth, he found that there was a submucosal cleft. So this is the importance of the each and every point. Next. Yeah, as we saw the signs or how to identify effective latch, we will see the signs of ineffective latch. So if the latch is ineffective, one I told him maybe we'll start modeling his face, head, and try to adjust the position. At the same time, if the latch is shallow, baby will try to hold the latch tightly, and for that he will make his lips tightly on the breast. He will keep his lips tightly on the breast, which will lead to tight first lip, and the lower lip will curl in. So if that sign is, and it hurts a lot to the mother. So if you see that position of the mother, you need to advise the mother to remove the baby by putting her little finger into the baby's mouth, break the suction created into baby's mouth, and then remove the baby and relatch the baby. Again, when the baby sucks, if there is dimpling of the cheeks, that again suggests that the latch is not correct. If mother reports any pain, as we said, no pain, correct latch. If mother reports any pain, that means incorrect latch. And we need to observe the mother's nipple immediately after feeding the baby. If the nipple of the mother is mishappened or flattened, or sometimes we call it as a lipstick tip, sort of that, when the baby clenches tightly on the nipple becomes like a lipstick, tip of the lipstick, then we need to relatch the baby. Next, please. Now we'll see what are the causes of poor or shallow latch. So there are multiple causes. We'll see one by one. The first and foremost is unexperienced mother, or a mother who she might be having second or third child, but if she has not breastfed the earlier children, so that mother also comes in unexperienced mother. Most of them are primaries. What is the reason of inexperience? Because nowadays we see the nuclear family, more of the nuclear family. We have 1 or 2 babies at the most, and they don't see how to breastfeed and how to feed the baby. They don't observe only. They don't know, because most of in the family I come across, when mother-in-law comes to me, they say, doctor, we have this baby after 25-30 years. This baby has come to our family, and now most of the time they are. I have forgotten also how to breastfeed and the tips, what care should be taken. So these are the unexperienced mother. Dr. Vani has told the story of gorilla. when in 1978 in the zoo, the gorilla was kept in the zoo, and because the gorilla was isolated, she was not actually knowing what to do when the baby is born. So she couldn't feed the gorilla, and the first baby died. And then the Alicia League comes into action, and most of many mothers went showed with their child to show the gorilla how to breastfeed. Then the gorilla came to know how to breastfeed. Therefore, when she delivered second baby, she could feed that second baby. So the importance of antenatal classes very much, because of nuclear family, she can't know how to breastfeed. She can attend the antenatal classes. She can find out which are the hospitals which are baby friendly hospitals, so that she will get all the ideal treatment and all the ideal support she has to get. Then there will be functional difficulties, like if the baby is weak. If the baby is weak, in case if the baby is born low birth weight, if the baby is born premature, there are some mother babies who are born with the cleft lip, cleft palate. There are some babies who are with the tongue tie. So the functional difficulty, baby can't latch properly. There are some skills need to take. Not all tongue tie babies will have latching difficulty, but the tight tongue tie babies will have the latching difficulties. Sometimes when the mother has engorgement, nipple goes inside, along with nipple becomes flat. Along with that, the nipple has areolar edema, so it becomes very difficult to latch. So, as Dr. Jyoti told you the process of RPS, how to reduce the edema over the nipple with the fingers. So that technique we need to teach the mother. So it is that. So these problems we need to take care of. Then the supplementation of breastfeed, the supplementation, sometimes it is not all the time baby needs the supplementation. There are only few indications where really the supplementation is indicated medically. Only and only that time if we give supplementation, and with the process, as Dr. Manisha just now told you, the problem of latching the baby onto breast can be taken care of right from the beginning. And on top of the supplementation, if the mother uses bottle, then it again becomes a cycle that everything Dr. Manisha has explained very nicely. Then I want to give one example of supplementation. It's okay, Manisha has covered. Because of lack of time, we'll move ahead. There should be in the center, which our responsibility, lack of skill support. Many of the hospitals the doctors, nurses, staff is not trained to give the breast milk supply. They themselves do not know. They themselves have their misunderstandings. So skill support is very important. And not only the hospital support, the traditional help, this mother do not get the traditional help. What happens if the mother is not able to latch the baby properly? What comments the mother gets? Mother most of the time, she gets the too much criticism. You can't do this, you can't do that, you are useless, or something of like that. The mother, because the latching and everything, it also depends on the labor experience. The mother goes through the variety of process, and on top of that she has to feed the baby, if we say 8 to 10 times. And how much time the baby takes per feed, we don't know. The baby, most of the time baby needs is the moral support and guidance. If you instead of criticizing the mothers, if you support the mother, what to do? If you can't if you can't give the support, give the mother the best help from where she can get the correct advice, like the lactation consultants we have all over the world. We have the lactation consultants, and they can be virtually even contacted on the virtual basis. Community support is also very important. Once the mother is discharged from the hospital, she should be referred. She should be given numbers of lactation help if she requires. So these supports are very important. Next, please. Now we'll see the effect of proper attachment on the duration of breastfeeding. It has been researched that shown that if the mother is discharged with correct latching technique, it is more likely that the mother will breastfeed her baby for the longer duration, and therefore this initial period of during hospital stay is very important. We need to teach the mother. There should be a hospital actually criteria that no mother should be discharged with if she is not able to breastfeed the baby. And our Dr. Prashant Gangal sir during his BFHI training always ask one question to the hospital staff. If we advise breastfeeding baby for till second birthday, and the mother is there with you only for 3 at the most 5 days, then what is the importance we stress on the breastfeeding to be established during this hospital stay? One nurse gave a clever answer कि सर अभी सीखेंगे तो घर जाके अच्छा करेंगे. So it is a training for both mother and baby. So I personally think that this hospital stay should be declared as a honeymoon period for both mother and baby diet, so that they can spend lot of time together with skin to skin and learn the skills necessary for the nurturing of the baby. Next, please. Less visitors should be advised during this hospital stay. Effects of poor attachment. When the attachment is not proper, we saw the what effects it causes. It gives pain and damage to the nipple of the mother. It leads to soreness of the nipple or cracks. Sometimes the cracks are very difficult. The skin also goes away. We see the mother, the half-eaten nipple of the mother. Sometimes we can't even see the nipple. That much trauma mother has with this improper, incorrect attachment. And the research has also shown that the pain is the most important cause for postpartum depression. And pain or cracked nipple is the second commonest cause for discontinuation of the exclusive breastfeeding or breastfeeding. So most of the time the mothers ends here only, short pin. They will not go into further points. But some mother who still struggles, then because of the latching is not proper, the breasts are not emptied efficiently. That will lead to engorgement. And because of engorgement, again the nipple will go inside, the nipple will become flat and it will further become difficult to grasp. And there is apparently poor milk supply, because the milk is there in the breast of the mother, but baby is not able to take it out. So apparent poor milk supply. So baby, because the baby doesn't get milk, baby fusses, cries, wants to feed often, and that again mother thinks that baby doesn't like my milk, that's why baby wants to feed often. Baby gets frustrated, and because baby doesn't get any milk, baby refuses to suckle on the breast. So this adds on the problem. Then because of that, this leads to supplementation. And because supplementation, it is very hard to digest. Baby sleeps for longer duration. Baby is not again ready to feed on the mother's breast. And because our body has its self-control, down-regulating system, autocrine control, and because of that, this mother will really have a poor milk supply. Because of real poor milk supply, this baby's frustration will increase, and baby will refuse to suck, and baby fails to gain, and this is the end of lactation. And this mother is landed up into lactation failure with the reason which can be prevented at all, and we can have a good outcome out of it. Next, please. So we saw the attachment, baby's mouth position on the breast of the mother. Now we will see the baby's position. When the mother takes baby for feeding, mother lifts the baby, mother turns the baby, then she will touch the, if you can see, I will just change my position of camera. She will touch the baby skin to skin. Mother, the head, shoulder and buttock should be in one line, and the baby is well supported. Neck, back and buttocks are well supported with the hand. We'll go in detail one by one. Why baby should turn? Because we see most of the time how the mother feeds the baby, but only baby's head is touched and baby's body is like this. If we ask someone to eat, keeping your head like this, and we ask them to finish your whole meal in this position only, will we be able to feed that, or will we be able to drink it comfortably? No, that's what the baby also goes through. Skin to skin touch is most important, as Dr. Manisha also told, because of the baby when is in the mother's lap near to mother, it gives the sense of security first, then it stimulates the oxytocin reflex, which is helpful for the milk transfer. So skin to skin support, head, shoulder, buttock, because that we discussed, and the support of the full baby. We should support the full baby. As what happens if the mother only supports, even the baby is turned and mother only supports the head or neck of the baby, initially this position is maintained, but as the baby goes on feeding and he gets some amount of milk, baby body becomes loose and baby will be turned like this and it separates. Then the skin to skin, baby goes away from the mother. Skin to skin doesn't remain. As the baby goes, the baby's buttocks also goes away from the mother, and if this hips of the baby extends, the baby's neck also tends to extend. It is a natural phenomenon. And because of that, again the deep latch baby will come on to the shallow latch. So baby, whole of the baby should be supported nicely. Next please.
Excuse me, madam. Actually,
Yeah,
we are needing your cooperation because we are running behind of time.
yeah. Okay, I will not explain in detail then. Okay. This is the mother's position. Sit comfortably with good support, because mother has to feed so many times, 8 to 10 times, and even if the baby takes for half an hour, if mother spends more than 4 to 5 hours in breastfeeding, and if she doesn't have the back support, back will start aching and the mother focus on the breastfeeding will move away. Mother, we ask the mother to hold the breast in she shape like this behind and touch the nipple of the mother to the upper lip of the baby, so that when the mother touches the nipple, upper lip, baby will try to open the mouth and try to latch more deeply on the breast. As soon as the baby opens the mouth, mother has to offer the breast. Next, please. And mother needs to interact while the feeding is going on. A brief recap, briefly I will explain why we tell the C grip and why not the scissor grip. Most of the time mother holds the breast like this. If you see my fingers can separate only this much. So the available area for attachment becomes less. So baby's latching becomes difficult, and as well as when mother presses like this, it can obstruct the ducts. So the milk flow also milk transfer also is affected. That's why C grip, not scissor grip. Next, please. Sometimes there is instead of C grip, sometimes we advise U grip, because when we eat sandwich or something, we hold the sandwich parallel to the lips and we don't eat like this. When the baby is fed in the lying down position, baby's lips become vertical. And if the mother gives the breast with this, like this, hold the mother like this, you grip from below, then it becomes easy for the mother to breastfeed the baby. Yeah. Next, please. These are different breastfeeding positions in which mother can feed. Next, please. Cradle hold. In this, the side where the mother is feeding, the baby is held on the same side. But sometimes what happens, if the baby's feed goes longer and mother's hand pays, and if she wants to change her hand, she can change the hand. Or sometimes if the mother is obese and has large breast, this portion gets obstructed. So mothers are requested to hold the baby in cross cradle. Next, please. So in this cross cradle position, if the mother is feeding on the left, she is holding the baby in the right hand. Baby's buttocks are in the crook of the elbow. Back is supported with the forearm, and the neck is supported from ear to ear. Nape of the neck. Not mother is not advised to press the or hold the head, because baby will tend to extend the head as a protective mechanism. This is more helpful because the tummy to tummy is more in contact, and the nose end remains open. In case of mothers who have large breast or obese mother, this space remains open and mother can hold the breast with the other hand. Very useful for short hand, large breast during engorgement and feeding the preterm babies. Next, please. Sometimes babies want to feed in one position only. During early postpartum period, if the baby also goes through a variety of experience, labor experience, if it is a vacuum, forceps, or even C-section, sometimes baby can get a trauma or something, baby has cephalohematoma, caput, and if the baby, mother wants to feed the baby on the right, mother has to switch the baby. But if it fails, baby doesn't want to feed the baby on other position. So what mother can do, shift the baby in the same side to the opposite breast. So without changing the baby's position, mother can switch the breast. Again, it is useful for obese babies, mother having large breast, premature babies, and if the mother has twins. So mother can take one baby, both the babies in the next piece. Football position. Yeah, the twins. You can feed the twins in the football position. And in football position, other positions, mother can take one baby in the cradle position, other baby in football position. Both the babies can be taken in the cradle position, crossing front with front claws, upright, different permutation combinations mother can use. Next, please. Sideline position. There is a big myth that mother cannot feed the baby in lying down position. As Dr. even Reshma has cleared this myth, as the baby always sucks in lying down position and baby sucks well on the lying down position. The mother's position doesn't matter much, but what are the advantages if the mother feeds in the lying down position? Next, please. Even if and it has been shown that go back. Next, actually, mother gets adequate rest. Why? If she feeds lying down, it helps mother to recover faster. It is helpful for the mother for night feeding. After C-section, after perineal tear, episiotomy, if the mother has hemorrhoids, large breast, and sometimes the hypertonic babies or hypersensitive babies, if they are held like this, they don't want to be held. So if the mother keeps the baby in lying down position, she just can touch the baby, and then these babies cooperate very well. Only thing we need to tell the mother, you can take a pillow to support your back, and babies also avoid over rotation of the baby, so that if both falls asleep, they will roll over on their back. Next, please. This is again one method where the mother having large breast can feed on the tabletop. Mother will support her breast on the table and feed the baby. We advise mother to keep this roll of napkin underneath the breast so that the breast lifts up and gives support to the breast. Next, please. This is feeding baby after LSCS in the OT table itself. This is very fresh photo. Yesterday only I got this photo. So generally even one baby, we can feed the baby in the OT. But for twins also, if the doctor, staff, nurses are more motivated, then they try to feed the twins immediately after birth. Next, please. Side lying or natural nursing, biological nursing, Dr. Manisha has just now explained everything. It is more helpful for rapid milk ejection reflex. Next, please. Some babies with congenital, and this is seated or straddle position for babies who have this congenital hip dislocation, have this harness over their hip. The babies are seated with legs on the either side of mother's legs, or babies can be held like this also. Babies with cleft palate and cleft palate, because of palate, the negative pressure is not properly generated into the baby's mouth, and there are chances of aspiration. So if the mother feeds the baby in seated straddle position, the chances of aspiration are less. Next, please. Dancer hand position for hypotonic babies and babies with Down syndrome. This is not that mudra of dance. It is these are the two persons, Danner and Kultur. So half Dan from Danner and Sia sir from Kultur. Dancer hand position where the mother holds her breast with this, and in this the babies, she holds the baby chin here, and when she gives a pressure on the baby's cheeks with her fingers and thumb, so as to have generate a good pressure, intraoral pressure, and have a good sucking. Next, please. Tika fold for again, if the baby has only cleft lip, the mother inserts the portion of her breast into the cleft of the baby to occlude that cleft, so that the negative pressure is generated well in the baby's mouth. And even premature babies, sometimes mother has to hold the baby breast. Next, please. Yeah, next. Breastfeeding is not always easy, but it is always worth it. Try, keep on changing. Given a choice, each and every baby wants to breast milk because it is the healthiest. Next. Breastfeeding is the mother's gift to herself, her baby, and to the herd. This year's slogan is also support breastfeeding for healthier planet Earth. Thank you very much for patient listening and bearing with me.
Thank you, madam. Thank you very much for delivering our informative session.
Thank you.
So now I am requesting Dr. Satish Tiwari to welcome Gillian Weaver, madam. And also requesting Dr. Reshma to present the slide.
Gillian madam, welcome on behalf of the organizers. Hello. Yeah, Gillian madam, welcome on behalf of the organizers and the Human Milk Banking Association of India.
Thank you.
We are anxiously waiting for your talk today.
Okay, thank you very much.
And thank you for accepting our request.
Well, I feel very honoured to be asked to give this presentation. So I thank you. I thank you all the organisers, whoever put my name forward. Thank you. I'm grateful, and I'm very happy to be joining you today. Before I go further, can I just check that the sound quality is good?
Yes, ma'am.
Excellent. Okay, well, if I can have my slides, then I will. And can I also just question about the time, because I know that you're running late, and my impression was that you had to finish at a set time. So do I have the allocated time for my talk, or do I need to try and make it shorter?
Yeah, madam, you have a time till 6:30. So 1 hour you have.
Lovely. Oh, well, hopefully I don't need 1 hour, but that's lovely. Okay, so if I can have the slides on the screen, please.
Ma'am, are the slides visible, ma'am? So
not on my screen, they're not, no, but let me see.
Yeah, we can see.
You can see them, but I can't. Oh, okay, that's tricky.
I'll try again, ma'am. I'll try again.
Thank you. I was able to see the previous speaker's slides. maybe I need to do something. Don't.
Is it visible now, ma'am?
No.
Dr. Arijit sir, is the screen visible?
Yes, it is visible to all of us, I think.
Yeah, I
Please
can
guide
see
me.
there is. I
Please
can
guide
see.
madam accordingly to join again if possible, I think.
Yes. Ma'am,
Okay, so sign in again, yes?
ma'am, I request you if you can rejoin the meeting.
Okay,
It might.
I'll do it now. Okay.
Yes, yes, ma'am. Yes, ma'am.
Okay, lovely. I can see them now. Thank you. So if they can go into, okay, fantastic. So as I said, I'm very grateful to be asked to speak at this conference, and delighted to be contributing to your celebrations of World Breastfeeding Week. My name is Gillian Weaver, and my specialty is human milk banking and the use of donor human milk. And I want to talk about using donor human milk in support of breastfeeding. But let me just say briefly that I have worked in human milk banking for over 30 years, and I currently specialize working internationally, working with the establishment and operation, developing guidelines and standards, and developing tools and resources for milk banks around the world. I was co-founder of the European Milk Bank Association, and also of two organizations that I will talk a little bit about during my talk. One is the Human Milk Foundation, which is a charitable organization that supports human milk banking and lactation. It's based in the UK, and it supports research and education. And then I'm also the co-founder of the Hearts Milk Bank, which is an independent human milk bank based in the UK. So if you can move on to my next slide, please, which states that I have no conflicts of interest to declare, other, of course, than that I do work in the field of human milk banking. So I do earn money from human milk banking. Thankfully, and so, you know, that could be seen as a conflict of interest when I'm talking about this subject. Very importantly, can I please say that the images, videos used in this presentation, they do have copyright, so please don't use them, particularly the images. The video that we'll show at the end, we're happy for people to use that as long as they give the source as the Human Milk Foundation. And yes, please don't take photographs. Okay, thank you. If we can go on to the next slide. So, thank you. Human milk comes in under different names. It's a very changeable fluid. We talk about human milk, but actually it changes so much. It's difficult to talk about it as if it's one product, and certainly it has different names. It's often referred to as mother's milk. In many countries, it's primarily talked about as breast milk, but throughout this talk, I will largely refer to it as human milk. It reminds us that that it is a product of human origin, and it's species specific. It's very specific to the human species. We can consider it in different ways, and it is considered globally in different ways. So in some countries, it's regulated and it's thought of as a medical product of human origin, or an MPHO, and as a therapeutic product. And the reason for that is that it is used particularly with neonates, but it's used to prevent and to minimize the effects of diseases. Globally, it is mainly regulated and thought of as a food. And of course, it is primarily a food for babies. It contains complete nutrition for human babies. There are some circumstances where babies may need some form of supplementary nutrients, but usually because of their specific clinical situation. Normally it contains complete and should provide complete nutrition for human babies, and certainly exclusively is suitable up to 6 months, and then of course beyond as part of a baby's diet for as long, I think, as mum and baby are happy to feed. I wouldn't put a time scale on it. And then, of course, human milk contains many components over and above the nutrition. It contains anti-inflammatory components. It contains pre and probiotics, so intimately involved in gut health. It contains specific anti-infective agents, and these differ, of course, between mothers. And in its initial raw form, it contains millions and millions of living cells. So it's a unique fluid, and we should think of it as such. If you can move on to my next slide. Thank you. So all of these unique components work individually, some work together to uniquely drive human brain growth. So the human brain, for optimal growth and development, is dependent on human milk, and also for immune system patterning. And all organs within the body, their healthy development is optimized, is enhanced when babies are fed exclusively with human milk. So if we can move on to the next slide. Thank you. I'm sure everybody is very familiar with this series of papers published in the Lancet in 2016, in which they didn't just suggest that there were some diseases that were less likely to occur in infants if they were breastfed. So it isn't just a means of helping to prevent gastroenteritis and asthma, eczema, and so on, but actually that most of the diseases of certainly of Western lifestyle have a basis in infant feeding, and globally so many diseases that are linked to how babies are fed or how they're not fed. And it's more than that. And I think one of the great advances in our knowledge about breastfeeding, and one of the best ways to promote breastfeeding in addition to the benefits and the advantages for babies, is that of course mothers who breastfeed are also likely to be healthier, and they're less likely to develop certain cancers and other diseases that may affect them much later in their life, long after they stop breastfeeding. So it's fascinating. If we can carry on to the next slide, please. This shows an infographic that I'd be very happy. It's freely available as a PDF. So if it's new to you and you would like a PDF of it, it was produced in collaboration between these two organizations, the Human Milk Foundation being one of them. I'm very happy for my email address to be shared, and you can email me, or you can the organizers can gather names if they wish, and we can email the PDF to people, and it just gives them, it divides all these hugely important components into specific groups. So moving on, thank you. So human babies, of course, as the previous speaker mentioned, and I have to say I very much enjoyed that previous presentation. But as she said, you know, human babies are born to breastfeed, but there are occasions when they may be too immature because they've been born very early. They just may be too small, too tiny. They may be too sick, or in some instances where the mother has insufficient milk, they may not be able to breastfeed, or they may not be able to get all of their breast milk feed from their mother. And so the question that everybody asks is what should we do about that? How best can we address the situation where we have a baby who can't feed directly at the breast, or where the mother doesn't have sufficient milk. And of course, first and most importantly, before we think about what we're going to give to the baby, we need to think about why this situation has arisen. What category does the baby and the mother as a dyad fit into to address this? And what can we do to make sure that that infant can receive all of his or her mother's milk before we start thinking about supplementing with another mother's milk, so with donor milk, or with another product? Before that, we need to work out what we can best do. Now, of course, sometimes it's an emergency and you don't have time to do very much, but these are all things that if it's thought about in advance so that every situation can be prepared for, then we can make sure that we introduce and ensure the mother is receiving the optimal lactation and breastfeeding support, so that if we don't have enough of her milk now, hopefully later today or tomorrow or whenever, we will have enough of her milk. But of course, there are many situations where some form of supplementation will be needed. If the mother is very ill, or if for some reason she isn't able to have a milk supply, we need to think about how we can make sure that we provide continuing support as well as providing an alternative. First and foremost, we would hope to supplement with human milk whenever we could. Human milk is so very different because of all the things I said before from the milk that is from a different species. Okay, so if we move on to the next slide, please. If we ask the question, why donor human milk, the obvious answer is because it's the one thing that most closely replicates that baby's own mother's milk. So a mother's own milk, her milk may be very different from another mother's milk, but in terms of the overall components and the overall constituents of the milk, someone else's milk will most closely replicate a mother's own milk, certainly much closer than anything else that's available. But the other reason for using donor human milk is because it's recommended by some very important organizations. I've just listed 3 here. The World Health Organization primarily, the American Academy of Pediatrics have long recommended donor milk as the second option, and throughout Europe, ESPGHAN. And I know that around the world, the international and the national organizations, pediatric, neonatal, feeding organizations, most will now recommend donor human milk as the second option. But there are some caveats, and if we go on to the next slide, we'll see what those caveats are. So the first will be, the first is talking about WHO, and they have long recommended that low birth weight infants, including very low birth weight, if they can't be fed with a mother's own milk, then they should be fed with donor human milk. But they caveat that with that the recommendation is relevant for settings where safe and affordable milk banking facilities are available or can be established. But we may ask the question, what does this mean in practice? What do we mean by safe and affordable? How safe is safe? And when we're thinking about affordable, compared to what? Yesterday, or may have been the day before yesterday, there was a very interesting paper published in the Journal of Human Lactation, and I would encourage you to read it because it's in the insights into practice and policy section of the journal, and the paper is called Donor Human Milk Banking: Time to Redirect the Focus. And in this, the authors, who are Penny Reimers and Anna Koutsoudis, who both have enormously experienced in the establishment and operation of milk banks and working with milk banking in South Africa and more widely in Africa. They ask the question, they very much focus in this paper on, what does affordable mean, and do all milk banks, should they all try to replicate the standards of equipment and facilities that are available in parts of the world where maybe human milk banking has been longer established. So I would encourage you to address that, to refer to that paper. If we can move on to the next slide. WHO were one of the prime authors of this policy brief that was published last year, together with UNICEF and the organization PATH. I'll say a little bit about PATH in a minute, but the policy brief was looking at ensuring equitable access to human milk for all infants, and developing a comprehensive approach to essential newborn care. And the policy brief looks at the current global policies that support not just the provision of human milk, but also the provision of donor human milk from milk banks. And it encourages and calls for policymakers to work to increase access to donor human milk for sick and vulnerable newborns. So, this, in my opinion, is very much required to oh, hang on, I've just lost the screen. Can you still hear me?
Ma'am, you can.
Okay, I'm back. Thank you.
Okay.
Right, I was trying to swipe something that appeared on my screen, and I lost everything. But I'm back. So they talk about integrated human milk banks. So where human milk banks are integrated into healthcare provision as part of overall breastfeeding and lactation support, and the provision of donor human milk, certainly in neonatal intensive care units. And they note that this can increase breastfeeding rates at discharge, and that it's an important initial step to establishing exclusive breastfeeding. So again, I would encourage you to take a look at that if you're not familiar with it. Just to explain, PATH. Thank you. Yes, you can move on to that slide. Thank you. So PATH is an organization. PATH stands for Program of Alternative Technologies for Health. It's based in the United States, but it works very actively across much of the world, particularly in low and middle income countries. Last year, and PATH has worked in support of human milk banking throughout Asia and South Asia and Southeast Asia over the past 4 or 5 years at least. And last year they published this global implementation framework that is a toolkit, a resource toolkit for establishing and integrating human milk banks. And this toolkit comprises around 11 different tools that are hugely informative and useful and supportive for anybody that is looking at establishing a human milk bank. And I think that they very much address how best to match how the milk bank is established with the local resources and the local requirements. So it's freely available. It can be downloaded, it can be viewed, and it's you can access it via the PATH website, but it's also available on a website called LactaHub, which is actually a complete platform, which was newly launched. It's only about a month old. And LactaHub, LAC, and I'm sorry, I should have put it on, and I can put it in the chat, into the chat. So lactahub.org is a resource for anyone involved working in the lactation and breastfeeding field. It is looking to bring together all the resources that are helpful for in support of lactation and breastfeeding. So do take a look at this toolkit if you're involved or interested in the establishment of milk banks. So moving on then to the next slide. So WHO have recently, in the context of COVID-19, made some recommendations that are pertinent to our topic here. And that is that they recommend that if a mother who is either confirmed or is suspected of having COVID-19, if she is not able to breastfeed or to fully breastfeed, the best way to feed her newborn infant is with donor human milk. So the same sort of caveats as before, that this is assuming that every effort and every support is given to enable the mother who has COVID-19 to be able to feed her baby. And this is part of the recommendations that talk about not separating mothers and babies, of mothers being able to breastfeed, mothers being able to express their milk, and their expressed milk is safe to use. So within all that, but if the situation is that the mother is not able to breastfeed because she's too ill, or she's been separated in some way and her milk is not available, then donor human milk should be the first choice. So it should come from a human milk bank, but it can be safely fed to the baby while the mother is recovering. Of course, I would say that everything should be done to help that mother to maintain her milk supply, maintain her lactation in the meantime. They then give some other instances that are also also suggested, but these should come after donor human milk. So donor human milk should be the first option in these instances. So if we can move on to the next slide. Thank you. So at this point, let's actually define what I mean by a human milk bank. I've talked a lot so far about a human milk bank, but I haven't actually defined it. This is the definition that I prefer. It comes from the organization PATH. And if you move on to the next slide, you'll see the reason why I prefer this definition, because the next slide highlights the phrases that I like. So if you can just move on to the next slide. Thank you. So the reason I like this definition, because it doesn't just talk about a human milk bank being a service responsible for recruiting donor mothers, collecting, screening and processing the donor milk, but it also mentions quality control, which is very important. The way a milk bank operates and the way the milk is collected and stored and so on very much impacts on the quality of the milk. So quality control should be a part of the definition, as should storage and the distribution. But then this definition goes on to state that the rationale for this is to meet the specific needs of infants, and not just infants, but also young children, because donor milk can have a role in the support of young children also, not just infants, in a health establishment or community for whom donor milk is needed, and this is the most important bit, while protecting, promoting and supporting breastfeeding. So the work of a human milk bank should never undermine in any way breastfeeding, and donor milk should always be there as something that can be used if, despite all the support and help for a mother, you don't have enough or any of her own milk. So if we go on, we can also look at the definition of donor human milk. And again, if you can go on to the next slide, I'll show you the parts that I like of this definition. So donor human milk is milk that has been expressed by a lactating mother, that is then processed by a human milk bank for use by a recipient that is not the mother's own baby, but that payment for the donated milk is not provided. And that's very, very important. Globally, there has been a trend towards the commercialization of human milk banks and the provision of human milk. Often these commercial concerns, they pay women for milk and they then are profit making. And I'm happy to say that I know that in India there have been important moves to outlaw the commercialization of human milk, and I'm delighted at that, because I feel that human milk banks should be part of the altruistic provision, and preferably not for profit. So moving on to the next slide. Thank you. So we know that human milk banking is increasing globally, and happily not-for-profit human milk banking is increasing globally, and donor human milk from a human milk bank is becoming more readily available around the world. And the next slide gives you an indication of this. So currently, if you can just move on to the map, thank you. So currently there are around 700 milk banks operating in about 65 countries, and both the countries that operate human milk banks, the number of countries and the number of milk banks has increased quite dramatically over the last decade or so. This map is from the PATH resource that I told you about. So it is a map that you can download and use, and it's being updated. So if you have information to update it, do please get in touch with PATH so that can happen. But you can see how milk banks, although they do exist pretty well globally, there are some very large parts of the world where either no milk banks or very few milk banks exist. But having said that, in many of those countries, they are working towards establishing their first milk banks. Brazil is very noteworthy in when you're ever talking about milk banking globally, because since the 1980s they have rapidly grown the number of human milk banks. There are around 230 human milk banks in Brazil at the moment, and they are integrated into the support services for lactation and breastfeeding. They are funded by they're funded nationally through the health services, and the Ministry of Health has been hugely supportive of the development, not only of the milk banks, but of all the support mechanisms to ensure that the milk banks are run optimally and safely. And they've been a very good model for other countries within South America. There are very many milk banks also throughout Europe. The history there goes back well over 100 years. But what's been very interesting to me is, since I first came into the field of milk banking, how many milk banks have been established throughout other parts of the world. Okay, so if we can move on to the next slide also. Part of the discussion, yes, and you can click through these. Thank you very much. That's lovely. Part of the discussion that doesn't always take place when thinking about human milk banking is looking at the ethical values, and particularly the values that we would associate with, for example, blood donation and transfusion, which are respect, beneficence, and justice, and there's great similarity, I think, between these. So if we move to the next slide, and just mention first of all respect. And respect is very much that any individuals should be able to make their own decisions regarding their bodies, and this certainly applies to both the donation of human milk and the use of human milk. And it's very important that milk banks respect the privacy, confidentiality, and any cultural sensitivities of not only the donors and their families and communities when recruiting donors and providing donor milk, but also of the recipient families. So respect, confidentiality, privacy are very important. If we go on to beneficence on the next slide, thank you. Then This is centers around always avoiding or minimizing harm. And of course, we would always want to do that in anything to do with infant feeding. Unfortunately, there are industries around infant feeding that don't apply the same standards, sadly. But within human milk banking and the provision of donor milk, our ethical practices should enable us to develop milk banks that always demonstrate the duties of care for donors and recipients alike. And those duties of care need to be very carefully considered. And particularly if you just, that's it, if you just look at that last picture, we're talking about very vulnerable, tiny babies often. And we should, our duties of care are obviously, you know, to them, but also to the mothers and the families of the mothers who donate the milk. That we make sure, for example, that we don't exploit women in any way, that we don't encourage them to donate more milk than is good for them or safe for their own babies, and that we always have those foremost in our minds. If we can move on to justice, then of course this is to do with equality and fairness. And sadly, in this world, equality and fairness is not always uppermost, but we want it to be within our healthcare provision. And so equality, there should be equity of access to donor human milk. There should also be equity of opportunities for donation and fairness in the allocation of the milk. Now, when thank you for that. So when I think about introducing donor human milk to neonatal units, there aren't only ethical considerations, there are also some clinical and some practical considerations that need to be taken into account. And the introduction of donor human milk to neonatal units, to feeding practices, to protocols on the neonatal unit, it's very important to think about all of these. This was a poster that I put together that outlines these, and again, I'd be happy to send the a PDF to this if anybody was interested. I'd be happy to email this. It just goes through this, the clinical and the practical, as well as the ethical implications of first introducing donor human milk onto a neonatal unit. Again, it comes back to this whole thing of making sure that we don't in any way undermine breastfeeding on the unit. It's interesting, I've visited countries, I've visited establishments, institutions where the question of why donor human milk is needed comes down to babies not having access to enough of their own milk. But when you actually look at why babies don't have access to their own mother's milk, I've found that mothers and babies are separated, that mothers are not able to be at the cot side of their baby if their baby is taken onto a neonatal unit, if they need to be cared for separately, that you know, if mothers are not supported to be with their baby as much as possible, to be able to have skin-to-skin care and so on, then you know, donor human milk is clearly you know, the next alternative. But there are things that can often be done to make sure that you optimize getting the mother's own milk. So if we can move on to the next slide. If we think about what donor human milk is replacing, if we use donor human milk, if we introduce it to use on the neonatal unit, the pediatric unit, well, first and foremost, we may be able to prevent the continued use of only IV fluids. And of course, long-term use of only IV fluids has many disadvantages for babies. It's an infection risk because of the lines going in. So donor human milk can bring to an end the continued use of only IV fluids. It can also mean that you don't have to not feed a baby enterally. So you can start to provide enteral feeds, and small amounts of enteral feeds are obviously very beneficial to their baby's gut, as well as providing them with important nutrition and all the immune protective components of the breast milk. So if your baby is nil by mouth because you don't want to feed them with an alternative to breast milk, then using donor milk means that you can introduce and start minimally feeding and then increase those. It means that you can avoid the use of formula feeds, and you can avoid the use of specialist formula feeds such as specific preterm formulas if those are used on a unit. And it means you can avoid the use of any unmodified animal milks, so ones that haven't been made into a specific formula. There are no milks from other species that are safe to use without any modification for human babies. Some are better than others, but all can cause problems for babies, as their constituents are so very different. The proteins are very different, and so on. If we can move on to the next picture, that's lovely, thank you. So unmodified animal milks, the one that's most used is of course cow's milk, but others are used, donkey milk and goat and sheep's milk. But as I keep saying, it's not to replace maternal milk. So moving on to the next slide, let's just ask the question, why donor human milk? Many people consider that if your milk has been, if breast milk, human milk has been heat treated, if it's been frozen, if it's been thawed and frozen again, and so on, that the damage that may be done to some of the components, that they must make the human milk not useful. And this is simply not the case, because despite the processes that take place in a human milk bank, some of the components, the essential fatty acids, for example, are not affected by these. Others are only partly affected. Human milk oligosaccharides are not affected by pasteurization and freezing. Lactoferrin and lysozyme are reduced, but there's still good proportions left, usually between 40 and 70%, certainly of the lysozyme, and again up to 70% of the immunoglobulins. So donor human milk, despite the processes, retains many of the important biologically active components, as well as maintaining the nutrition. So that's one of the very good reasons for using and considering donor human milk. Another good reason, before I just touch on this slide, is that you're giving a very positive message to the mother and to her family about how you want to feed babies. If a mother doesn't have enough of her own milk for whatever reason, and you say, well, you know, until we have more of your milk, we would like to use donor human milk, then you are really underlining the fact that it's very important that babies are fed with breast milk. As soon as we start to offer milk, whether it's a formula milk or an artificial or breast milk substitute, or an unmodified animal milk, then we are undermining the importance that we give to feeding babies with human milk. In terms of preterm babies, of course, there is a good deal of evidence why donor human milk should be used, in that we know that it reduces the risk of necrotizing enterocolitis, but also it reduces the incidence of retinopathy of prematurity, of bronchopulmonary dysplasia, and it reduces the length of stay. It's been shown to reduce the length of stay of a baby in hospital on the NICU. And if you just click, it also has led to the increased breastfeeding rates on discharge of the mothers and babies. And of course, if mothers and babies are discharged from hospital breastfeeding, then that sets them up for all the advantages, all the ongoing advantages that we know are linked to a baby being breastfed. Or shall I say, it avoids the disadvantages of babies being fed any other way. So if we can move on to the next slide, please. And just to mention again, the reduced duration of hospital stay. This is because donor human milk is much better tolerated by babies than any milks from other species, including any infant formula. And it's particularly easier for preterm as well as full-term infants to digest. And we know that certainly in the UK, that babies who are supplemented with donor human milk on average spend at least 1 day less in a neonatal intensive care unit. And the cost savings are enormous when you add all those days together over a year for all the babies that can benefit. This isn't just about costings, but it's certainly what what influences a lot of hospital policy. And so knowing that you can reduce the length of stay, of course, the sooner a baby is able to be discharged and to be with their mother full time and for them to be able to go home to the community, then the better. But the other very important reason that I want to just go back to that was mentioned, so if we can go on to the next slide, please, is the increase in breastfeeding rates. Now, this slide here refers to some evidence that was published from North America, where they have again a very long history of human milk banking, and certainly the extent and incidence of the use of donor human milk for hospitalized babies has grown tremendously over the last 10, 20 years, and there are many more human milk banks in North America now. And this looked at a number of hospitals where donor human milk was introduced, and they looked at the breastfeeding rates on discharge before the introduction of donor human milk and after the introduction of donor human milk. And with only 2 exceptions, the incidence of breastfeeding rose, and in many instances, as you can say, rose dramatically. So the dark colored line, each pair of lines represents one institution, and the darker color was before the donor human milk, with the lighter color afterwards. And as I said, in all but 2 instances, the incidence of breastfeeding on discharge increased. And for me, actually, this is the most important benefit of having donor human milk available, is that it gives this powerful message that you really do want babies to be fed with breast milk, and that in turn influences the mothers and the family. So if we move on, and I would say also that I know that the experience in India where donor human milk has been introduced is very similar, and that that there are certainly publications from India where that mirror this, that have had exactly the same experience and have found that babies are more likely to go home breastfeeding if donor human milk is available. So if we can move on to the next slide, please. Thank you. So I wanted to just show you this as an example that of how babies on neonatal units can be that there is certainly within Europe there has been a tendency to only use donor human milk with very premature babies, which I personally feel is very unfortunate, because I think that the benefit to all babies is striking. but this just gives you an example of how only certain babies, only the most premature and the sickest babies were able to receive donor human milk. And this is widespread throughout much of Europe and in other parts of the world as well, that donor human milk is prioritized for these types of babies. If we go on to the next slide, it also shows you that the use of donor human milk is not for very long. So where babies are between 32 and 34 weeks, it may only be used for a few days after delivery, and in lower gestation babies until full enteral feeds. And if you have a mother who is taking longer to establish her lactation, it means that there's an awful lot of pressure on her. Of course, assuming that she's being given the optimum support and help, the practical support that she needs to be able to increase and establish her lactation. But ideally, donor human milk, if you have a milk bank that uses it appropriately, then you will have enough milk to be able to use it more widely throughout the hospital. And this, as I said, was the sort of scenario. In some instances in the UK, it's only babies born less than 28 weeks gestation that are deemed suitable for donor human milk. This has partly been because of lack of supply. So if we can, which I will address later on. So just to kind of wind up and just to reiterate that the reasons for using donor human milk, in addition to reducing length of stay and increasing breastfeeding on discharge, are to prevent the long-term sole use of IV nutrition, to avoid formula, which we know is implicated in the pathogenesis of NEC, of higher rates of sepsis, induced inflammation of the gut. We know that if we feed babies with formula, it will disrupt the gut microbiota, lead to a suboptimal microbiome. But we also know that if we provide donor human milk, we don't just provide the nutrition, we provide many of the immunoprotective factors that are present in maternal milk, but not present in other alternatives. But also, very importantly, to promote breastfeeding. So if we can go on to the next slide, please. I would like to just ask this question. So we know there's an enormous experience globally of using donor human milk on the NICU. But if the availability and the appropriate and considered use of donor human milk, if it increases exclusive breastfeeding rates on discharge of preterm infants, will it not have a similar impact on mother-baby dyads outside of the NICU and also in the community? I would suggest that it will do because of the very positive message that it gives. But if we can go on to the next slide. There is some evidence now that backs this up, and a very recent paper published from North America looked at using donor human milk not just in the NICU but on the postnatal ward, so for babies that were well, and this may they may have been born early, there may be low birth weight, they may be but not requiring specialist care on the NICU. And they looked at the impact on the exclusive breastfeeding rate at 6 months of life of introducing supplementary donor milk into this newborn nursery. So this was not where very sick babies were. And if we go on to the next slide, they wanted to look at breastfed newborns who needed supplementing because of hypoglycemia or hyperbilirubinemia, or because they'd lost more than 8% of weight loss. In these instances, what would happen if you use donor milk rather than other supplements? So they did a retrospective review on 122 infants, and looked at them 4 months before the implementation of the donor milk policy, and 6 months after. And if we go on to the next slide, we'll see that the impact of this was that of the babies that received formula, fewer were still breastfeeding at 6 months of life. So when they did the logistic regression, the babies that received donor milk were 5 times more likely to be exclusively breastfed at 6 months of life. And so this to me is a very positive start to gathering the evidence that of the importance of widening the use of donor human milk where possible. So, so the conclusion was obvious that supplementing newborns with donor human milk leads to increased exclusive breastfeeding at 6 months of life, which is hugely beneficial for that baby, but also for that baby's family. If we go on to the next slide, you may say, well, that's all very well in North America, but are there any instances elsewhere? And this was a retrospective look at babies who were being fed in South Africa with donor human milk. It was published a few years ago now. It was based on a case series from KwaZulu-Natal. And if you go to the next slide, it's a case presentation of 7 case studies. And it looked back at babies who had entered an orphanage either because they were orphaned or they were abandoned. And the orphanage had an attached human milk bank. Now, many of these babies had been exposed to HIV, or they were already known to be HIV positive. And they were all fed exclusively with pasteurized donor human milk once they were admitted to this orphanage, and their progress was reported. Now, this went back over quite a long period, and unfortunately, many of the babies had arrived at the transition home without extensive medical notes, and so how they'd been fed previously was not always known, and so only their progress within the home could be taken into account, and there weren't always detailed medical records available. But what was shown, and the authors would say, particularly Professor Koutsoudis and Penny Reimers, who were the people on the ground running the human milk bank and involved in feeding these babies, that there were no negative impacts of using donor human milk as for long-term nutrition for these babies. But the positive evidence, the positive effects, the protective effects against failure to thrive, against diarrhea, against atopic dermatitis, and against just opportunistic infections. These babies did so much better once they were fed with donor human milk, and compared to other babies. This Professor Koutsoudis and Dr. Reimer are now following up other babies, and certainly much more detailed information is now available. But if we go on to the next slide, so this makes me think a little bit about the human milk banks that are available, because human milk banks don't fit one model. The human milk bank in KwaZulu-Natal was community-based. It was based, as part of it was set up, established specifically for these babies in this transition home. As I said, most of them either orphaned or abandoned, and it was not for profit. but of course, most human milk banks globally are based within a hospital or a health facility of some description. They may be very separate. They may be attached to the NICU, the neonatal unit. There may be a separate entity within the hospital. In Brazil, they're all part of the breastfeeding support mechanisms within the hospital. They may be funded and resourced on a local basis. There's a move, I think, globally to establish regional human milk banks, and in some cases there are national services that operate. And I've been very interested to watch from afar, but also to be a little bit involved along the way of how human milk banks have grown and become established throughout India. And then, of course, some milk banks globally operate independently. So they provide donor human milk to hospitals, to health facilities, but they're not actually funded by the hospital. They may be funded charitably, or they may be funded in another not-for-profit model, so a social enterprise. So there are no profits, or any profits are ploughed back in to support the enterprise to be able to feed more babies. So there are very different models globally. Guidelines differ hugely, recommendations differ hugely globally, and there's no reason why human milk banks should operate in exactly the same way. The risk benefits differ in different scenarios. Access to equipment and facilities differs, and I think what is very important work is to look at how to develop minimum standards for sure, but then how to raise those standards within the context of the local of the local region. So if we can move on to the next slide. So I said I would tell you a little bit about the Hearts Milk Bank that I co-founded with Dr. Schenker, who I believe is speaking tomorrow as part of this program of events. We established the Hearts Milk Bank as the first non-hospital, non-health service based milk bank. And the reason we did that was because there were many hospitals that were finding it impossible to access donor milk. So if you look at the map of the UK, you can see that's where the milk banks existed. And if you just click again, the big drop where London is represented 3 or 4 human milk banks, but 2 of those suddenly stopped being able to provide donor milk to other hospitals throughout London, and all of a sudden there was no access, and there were many hospitals across certainly the southeast and the east of the country that didn't have access to donor human milk. And so Dr. Schenker and I wanted to address this and to develop a human milk bank that wasn't attached to a specific hospital, but that would be able to make donor milk available. So if we move on to the next slide. We did this, and we were quickly able to supply, within 2 years, we were supplying donor human milk to 30 different hospitals across the region. But we found that we had a surplus of donor milk, that we were able to recruit donors very easily, and we had enough milk to be able to think about providing it to babies in the community. But we also wanted to be able to support the development of educational resources and to be able to support research to answer many of the questions that we have. And so we established together with some other colleagues, we established the Human Milk Foundation, which is charitably funded. So it's a charity, and it pays for the milk that is provided to babies in the community, and it also pays for the research and for development of education and the support of human milk banking in all sorts of different ways. And if we can move on, and I would encourage you, do please visit the websites of these organizations. Be happy for you to to go, and do contact me if you have any questions. So if we can go on to the next slide. The community provision that we've provided has been to mothers who've had bilateral mastectomies as a result of breast cancer, mothers who are currently undergoing treatments for breast or any other cancers. And I have to say, we've provided donor human milk to very many babies who were unable to access any of their maternal milk, their own mother's milk, because their mothers were undergoing chemotherapy. And so we're unable to breastfeed. We also provide it to babies whose mothers are taking medications that mean that they're unable to breastfeed. The most notable is when they're taking antipsychotic medication, but there are a few other medications. Sometimes it's short term, other times it's longer term. And to mothers whose babies are HIV positive, if they need short term supplementation with human milk, then whilst they're establishing breastfeeding if they're HIV positive. And in some instances, it's a combination of several of these things. We have a prioritization panel, a panel of experts, but also that has members who represent families who receive donor human milk, represent donors, represent breastfeeding support organizations. So we have a very wide ranging expertise on the panel, and together we prioritize. We've looked at how best to prioritize and how long to provide donor human milk for, as long as we have the supplies. And so far, even throughout the COVID-19 pandemic and ongoing, we've been able to ensure enough supplies of donor human milk, thanks to the enormous generosity and hard work and kindness of donors who've gone out of their way to continue to donate or to start donating milk, despite the additional challenges and obstacles that are put in the way of mothers wanting to donate during these times. So, for example, it's more difficult to get blood tests done. It's it may be more difficult transporting milk and so on. But despite that, we've found that we haven't had difficulty in ensuring that we've been able to meet the request for milk. If we can go on to the next slide. The other reason for providing donor milk is where mums are just struggling to provide enough. So healthy mothers, healthy babies, but where there's just not quite enough milk, and provided enough milk for a few days to be able to supplement that baby whilst the mum establishes her full lactation and breastfeeding. One of the things I would say is that in any instance where babies are being supplemented with donor human milk, as you would do, I hope, if you were supplementing with anything else, is to ensure that the means of supplementation doesn't interfere with breastfeeding, so that not introducing feeds that stop the baby from going to the breast. So if a mum is increasing her lactation and breastfeeding and establishing breastfeeding, obviously introducing bottles is problematic, but also giving a baby a feed when they haven't fed at the breast, so aren't stimulating the own mother's milk supply. If the baby is being tube fed, well, then obviously the baby can be tube fed whilst feeding at the breast. But there are means of supplementing babies without disturbing their time, making sure that they're still getting plenty of time feeding at the breast, and so stimulating the mother's milk supply. If we can go on to the next slide, I want to very briefly just mention World Day of Human Milk Donation, and if we've got time, just have a quick look at this film, which illustrates how milk banks across the world have come together to a virtual group that put together a film for World Day of Human Milk Donation, but also we've referred to it in our 2-year celebration. So if we can just play the film, it just lasts a couple of minutes. Can everybody hear it?
Excuse me, Reshma ma'am. You need to put your microphone on first, I think. I'm not able to put your microphone on from my end.
Ah, right.
Am I audible, sir?
Yes.
Yes, right now you're audible.
I'll play it again. Just let me know if it's audible.
Yeah, now it is audible.
Okay, sir. I'll make it full screen. I am not a stranger to the dark. Hide away, say we don't want your broken parts. You to be so divine. Run away, you stay. No one will love you as you are. I won't let them break you down to dust. I know that there's a place for us. For we are the warriors. Sharp words wanna cut you down. I'm gonna send a blood, gonna drown the mind. I am brave, I am true, I am who I'm meant to be. This is me. So now, here I come. And I'm marching on to the beat I drum. I'm not scared to be seen. I make no apology. This is me.
What we're experiencing is a huge volume of women who want to donate this precious gift, and that's where we're calling on extra investment support from government. When the sharp words wanna cut me down, I'm gonna send a blood, gonna drown mine. This is brave, this is bruised, this is who I'm meant to be. This is me. I'm gonna send a blood, gonna drown mine. This is brave, this is bruised, this is who I'm meant to be. This is me.
Thank you. So that was our second birthday celebration. So you can see in 2 years we've come a long way and done a great deal. If we just go on to the last slide.
I'm so sorry. Yeah, I'm so sorry.
No, that's fine. And you can have a look at this as well later. Maybe people can take a look at it because there's the second one as well. But just to finish, so the second last slide, the next one, thank you. So I just wanted to say that globally, but particularly in Europe, the focus of many policymakers and clinicians has been on the use of donor human milk to prevent mainly necrotizing enterocolitis, and that's very natural. It's a devastating disease, and it's a huge impetus to invest in human milk banks. But I believe that the potential wider benefits for families are immense, and that the power of the provision of donor human milk more widely, as long as it's appropriately used in support of breastfeeding, that the positive impact it will have on breastfeeding itself is a very powerful argument to use donor milk more widely and to increase the use and to invest in it. However, we do need more evidence. So I say over to you, all of anyone in the audience who's using donor human milk, do think about using it more widely and helping us to gain that evidence. I appreciate that time has run on. I took you at your word and took up the time. I'm very happy to answer questions by email later. And so I wish you all a very good evening. Thank you for your attention. And I hope that you found this insight into my world of human milk banking interesting.
Thank you, madam. Thank you very much for your presentation, and we are very much thankful to you for being with us. So now I request Dr. Satish Tiwari to say something.
I think it was an excellent presentation, especially the work done by the Human Milk Foundation. And we compliment and congratulate you on the 2nd anniversary of the Human Milk Foundation. We hope the good work continues in future. And now all of us, Dr. Arijit Karmakar, Dr. Reshma Jain, I do not know whether you're a doctor or not, but all those who are associated through this e-conference this year, we will all work together to have this movement, make a movement all over the world for the birth and fundamental right of each and every mother and the child. Thank you, Gillian, again for accepting our invitation and giving your talk in such a nice way.
Oh, thank you very much. I wish I could have seen more of you, but I'm very happy that to have been able to share this with you.
This is just the beginning. That is what I said. This is just the beginning, and we'll see much more development in this movement in the coming years.
Yeah, and I have to say, I've been so hugely impressed by the input of you and all your colleagues from India in terms of the global movement. You were far and away the most active in sending us all the pictures for the World Day of Human Milk Donation, in interacting with colleagues and so on the virtual network, so it's been a privilege and a pleasure to work with everybody.
Yes, definitely. Dr. Arijit, your comments, please.
Yeah, thank you. Thank you very much for being with us. So now I would request Dr. Reshma Jain to say something, because we have received so much cooperation from your end.
Thank you so much, ma'am, for such a lovely talk. We are really, really pleased to have you with us, and it was really nice to hear to you.
Thank you.
Reshma was the person behind the curtain today.
Oh, thank you.
Dr.
So,
Ahuja, sir.
so
Dr.
Dr.
Ahuja
Kulkar,
is
Dr. Alka Kuthe is also there. So I would also request her to say something.
Hello. Actually, really heard a wonderful lecture by madam, and so many things
you.
to learn from her. So many things to learn from her. Wonderful, excellent presentation about the work, and we are already working in India for Human Build Bank. So, like to be associated with the World Organization in helping the human being, helping the innocent child to gain his or her birthright.
Thank you. Thank you.
Okay then. So we are very much thankful to all for being here. So now I'm going to close this session. Okay
Okay.
then. So
Okay.
we'll see you
Bye-bye, everyone.
tomorrow.
Bye.
Bye.
Thank
Bye
you,
bye
ma'am.
everyone. Bye.
See you. Bye bye. Bye bye.